The following is a Shaw Public Affairs presentation.
Mental illness is never going to be invisible, so we have to help bring it forward and put it in front of us and say, now how do we deal with it?
Good evening and welcome to Voice of BC. I'm Vaughn Palmer, and it's been a busy year for politics in British Columbia, and we've done a lot of shows on leaderships and elections, and I'm sure we'll be doing a lot more. From time to time on the show, however, we try to do a show on just an issue, one that we think probably hasn't been explored nearly well enough, and something we can do for an hour on this show. Tonight's topic is going to be mental illness and a lot of the challenges around that for public policy, for understanding it. And to help us navigate all the way through this topic, I'm very happy to have on the show British Columbia's Chief Medical Health Officer, Dr. Perry Kendall. Thanks for being on the show.
Thank you.
And also, former head of the public service, regular on the show. There probably isn't a ministry in government he hasn't had his finger in at one time or another, Bob Plecas. Thanks for being on.
Thank you.
Yeah. Dr. Kendall, let's start and talk just about the challenge of understanding the issue here, because just from the notes you sent me, it's so much more complicated than the shorthand mental health that people hear.
Yeah, absolutely. And I think for years it's been something that health providers and planners have actually been wrestling with, trying to bring it to some degree out of the shadows, because there's been a lot of shame and stigma attached to mental illness. And now we know that there's this concurrence, this crossover with substance abuse disorders, and they, if anything, are even more stigmatized than the mental illness piece. So trying to bring the two parts of the system together, to get them recognized, to look at the upstream determinants that make some people much more vulnerable than others, to get a system that can respond rapidly and in time. And the system, up until fairly recently, has not been that responsive at the primary care level as well. So there are a multitude of problems, and certainly my experience trying to plan with these goes back some 25 years in Ontario, in Victoria and Vancouver, and the issues remain the same, though I think that we're making progress, slow progress, but definitive progress in a lot of those areas.
Bob Plecas, as someone who's taken these issues, taken them in government, taken them to Treasury Board, seeking funding and stuff, it strikes me that Perry referred to the stigma. It also strikes me as something that's driven by a very small number of very bad examples, of extreme cases.
I think you find that what we are familiar with is the homelessness and addiction issues on the street. And we don't understand very well, and Treasury Board never understands very well, that 20% of British Columbians have some form of mental illness. The impacts of the mental illness, mental health, is huge on this province, probably estimated at about $7 billion in lost productivity. In addictions, you add another few billion. Alcohol alone, add $1 billion in lost productivity. Those are really huge issues. But what we focus on is a little tiny bit at the front end around housing, addictions, homelessness, and we forget that we all have a stake in mental health. Mm-hmm. And because of that, we don't get enough funding to help drive the system to do preventative work in an area that essentially needs it.
People often say, well, they hear of an extreme case. And we're not going to talk a lot about extreme cases, but that's maybe what they connect to. Or they think of something very severe, schizophrenia, mm-hmm. or breakdown. And yet, depression, dementia, mm-hmm. with an aging population, those are the sort of things we're dealing with as well, right?
Yeah, absolutely. I mean, the total, if you look at the global burden of chronic illness, mental health and mental health disorders are way up there as one of the largest components of disability and disability-adjusted life years lost. And certainly with the aging population, the dementia issue is going to become more and more severe. I think we've got roughly 50,000 people living with dementia at the moment. By 2025, that's going to approximately double and look closer to 90,000 people.
And people think this is something you just manage with drugs.
Yes, well, in the area of dementia, it's really quite fascinating because I think the pharmaceutical companies would really like to find a drug that worked really well. All of the drugs that we currently have available can make some minimal impact. Whether it's actually clinically significant, whether it keeps people out of institutions is doubtful. There was some really good work done in Australia where, with the onset of dementia, demented individuals who had families were brought into a kind of 3-week intensive management program, learning what the prognoses were, how to manage your house, what to look for, how to cope. And that intervention lasted for about 5 years in terms of its effectiveness. And when they went head-to-head against the anticholinergic drugs, it actually did better. And these people maintained independence, they maintained functioning, and they stayed out of institutions for longer. And it was actually a much more cost-effective intervention because it built the community support around vulnerable individuals.
Were you in the public service when deinstitutionalization happened?
Yes, I was in the public service, and that happened 20 years ago or so,
Yeah,
25 years ago now. And at that time, it was the same argument that we will provide the programs and we will provide them in communities to pick up this slack that's going to be created. And we did that to some degree. And then we started to get the world phenomenon of homelessness about the 80s, and the two were linked together. I don't know really how strong that link is, but we've got that problem as well, and there leads to simplistic answers like, well, only if we had institutions we could get rid of homelessness. And that's one of the problems that we face here. People make very simplistic links, and people want to treat mental illness not like a chronic illness, but more like something you can go to the hospital and in 6 weeks it's fixed, when rather it has to be managed over a long time. But on the providing programs front, I always say there's enough blame to go around with both governments, both the New Democrats, the Socreds, and the Liberals, for not providing the funding that's needed in this program area, that no one has to be embarrassed because they all should be ashamed.
But is it difficult to get funding from government for a group that can't speak for itself and doesn't necessarily have a lot of advocates that connect to government in the way that, say, everyone ends up using the health system on a regular basis, right? And the education system has, at both levels, has a fair amount of. Those are the public services that people relate to. Something like this, if you have someone in your family, obviously, but is that a challenge, getting that through government and getting that to be a priority?
Absolutely. I mean, you don't have the lobby groups. You don't have doctors. You don't have nurses. You don't have teachers. They have a big stick, and that squeaky wheel gets oiled. And you always go in, and when you're going in, we don't have any government in Canada. We don't have many governments in the world who will say we're going to take on health care spending. And so you draw a ring around it, you protect health care spending, and all of a sudden every other ministry suffers. But when protecting health care spending, when you go to Treasury Board, you go with your base budget, and then you line up the programs you want in front of that, and you line up heart surgery and hip replacements, and down the list is mental health is way down. And when they cut somewhere, it's the ones down the list that get cut off. And it's a very difficult sell to sell Treasury Board, either the staff or the politicians, that if you only give us more money today for prevention, we'll save you money tomorrow. And in a place where money is scarce, that's a very poor sell.
Have you seen a lot of changes in the programs in the time you've been doing this?
Yeah, considerably. Just to comment on what you said, Bob, I mean, Wilbur Keon, who was heading up a Senate committee on population health and prevention, sort of pointed out that the extra dollars that we're spending on health care, if we keep budgets fixed and taxation low, which is what everybody wants, that money comes from housing, from education, from income supports, from the very things that actually can sort of build a strong primary base in early childhood development, which has a really positive impact further on down the road. There's another dimension to the funding thing, though. If you go on putting money into stuff that doesn't work or isn't done well, I think the other dimension is that you need to bring the learnings and the skills and the tools forward so that, I mean, if all you're hoping is, oh, my success rates some more money, then you're probably not going to get very far in this current climate. But there's a lot that can be done with tooling up primary care practitioners, with training psychiatric nurses, with providing supports, with focusing the programs. I mean, the example of spinal surgery in Ontario, which you would recently have heard about, when 90% of the people who are on the wait list to see the specialist don't actually need to see a specialist. Saskatchewan put in a little program which enables GPs to feel comfortable about screening out those who don't. You could save and reinvest a lot of money. I think we can do a lot of that in the redesign in primary care, supporting primary care, giving primary care practitioners tools to manage early onset anxiety and depression.
So that's good to hear. John Richardson, who puts this show together for us, has lined up some very good comments, questions, and we're going to start with a couple of people you need to hear from. Here's Daphne and Bruce.
I did take a few mental health days, but I didn't want to share it with my employer. I was under a lot of stress with work and with dealing with family elderly problems, and I thought that I would be considered a person because of if I shared that I was dealing with mental health issues.
So many things for cancer, which I've gone through. But as soon as the word mental health is mentioned, or mental, that word, everybody puts up a wall and a screen, and they don't talk about it. It's got to come out.
It does take a lot of strength to admit that you have a mental health problem.
Even though we know so much of this is medical, that's still true.
Yeah, absolutely. I mean, one of the pillars of the Kirby Commission, the National Review on Mental Health, is trying to deal with stigma. Almost any plan you have to put in at a provincial, territorial, federal level, one of the components has to be managing and dealing with stigma and reducing the stigma, both that people feel if they feel they have a mental illness or they're depressed, or the provider side, or the employer, or your workmates, the folk around you.
Rafe Mira had a wonderfully eloquent little thing he did on the radio. I'm sure he's done it in a number of forums. And he said, I'm a diabetic, and if I don't take my medication, I'm in pretty bad shape. I suffer from medical depression, and if I don't take my medication, I'm in pretty bad shape. Nobody stigmatizes me for being a diabetic. Everyone, they didn't mean everyone, but lots of people stigmatize me for depression.
It is the way of the world, isn't it? Because it's something we don't understand. And our culture is such that we wanted to find, or we identified diseases that we could cure, and those people got great recognition. Today it's a Rafe Mayer or some other celebrity, when they come out and admit they have depression, it's a news story. Because people have not yet become comfortable enough with the fact that mental illness is an illness that we all have in our families and in our friends and in our neighborhoods. We just need to learn how to deal with that publicly. Would go a long way, Perry, I think,
absolutely.
For all of us to do better in this area.
Here's somebody talking about it. You'll recognize him, Gordon Campbell.
You know, I think it's really important for people to understand that, you know, mental illness is out there, depression is out there. You know, it's really interesting because, you know, my father committed suicide, right? And I wasn't told for a long time that he committed suicide, and I think that was clearly because people were embarrassed or they weren't sure how to deal with it, right? We have to remember that actually that is taking place in families in all of our neighborhoods, in all of the communities of the province, and we have to find a way that we can treat depression or schizophrenia, you know, in a way like a broken leg. Now, they're much more complicated in some ways. You know, they're mysterious, they seem invisible, but we have to be willing to provide that support, and I think government's got a role to do.
Perry Kendall, is it just because it's seen as untreatable?
I think that there's a kind of sense of if you pulled your socks up and gone on with life, you could deal with it. There's a sort of moral fallibility or a lack of moral fiber somehow in the background of some of those judgments that people make around mental illness. They certainly continue to make them around substance use issues, you know, in spades.
And Well, we'll talk a little bit about that, because I know when you sent me those notes ahead of time, you said the concurrent problems of mental health and addiction, which for some people anyway, go hand in hand. Right?
Mm-hmm.
So is it because you have a tendency to be addictive that you have the mental health issue as well, or are the two related that way?
It can go either way. There is not everybody with a mental health issue clearly has a substance abuse problem or addiction. Not everybody with an addiction, i.e. a tobacco smoker, has a mental health problem. But there is an overlap, and I think that the parts of the brain that are susceptible to addiction and the same kind of vulnerabilities that make younger people susceptible to substance use and have a crossover with anxiety disorders and with depression. And we're learning a lot about childhood development through epigenetics, which suggests that if kids are raised in safe, secure households with parents who love them and hold them and trust them, they're going to be a lot more resilient to the pressures that somebody who's brought up in a broken home, or who's abused, or who's neglected, or who has some fetal alcohol syndrome disorder or degree of ADHD or some other underlying condition. They're much more vulnerable to both the anxiety and the depression and the lack of connectedness to their communities or their schools, and they're more likely as well, I think, to be susceptible to the anxiety, the depression, to substance use, and you can get the two together. A lot of first-break schizophrenics, one of the reasons why it's really important to try and access those folk really quickly with adequate medical treatment is the longer they're out of treatment, the more disoriented and stigmatized and unconnected they become, and the more they're tempted to go into self-medication. So a lot of the small group of people you see in the streets wandering around are people with chronic schizophrenia, poorly treated, who are basically trying to treat themselves with cocaine or heroin or speed or whatever it is that's around there. So I think a lot of addiction comes from just trying to feel better, and that's some of the self-medication, which of course in the long run ends up doing you a lot of harm.
We've talked on the show before, Bob, about the challenge of priorities or problem solving in government, where it's spread over a bunch of ministries. And clearly, in just listening to Perry, this was one that touches on a bunch of ministries, which I suppose makes it harder to organize everything so that all the services are there for the person who needs them.
It's almost impossible. I think there's 5 or 6 ministries right now, and I think one question a government should ask themselves is whether they should be pulling mental health out of health and structuring a ministry around this all-invasive subject, especially as we go forward with the increase in dementia and Alzheimer's that we're going to face in the next, as you were pointing out, in the next few years, because they're the poor cousin in that ministry right now, that ministry that gobbles up everything else. And you might want to try that. I'm not a big believer in structural change to get efficiencies, but in this case, this may be the idea that has some success. Because we talked a bit earlier about how we didn't have advocates. The chap who was on before the clip there, called Gordon Campbell, he had first-hand experience. He understood the issue, or as he used to say, he got it, and yet it still suffered from lack of attention and lack of funding. And if you've got the premier, you should be able to overcome those things. But when it came to face who got what in health, hip replacements, angioplasties, all of the things that get votes, this is a tough one. And I think something dramatic has to be done, like set up a new ministry.
Jennifer Charlesworth, Federation of Community Services. Here she is.
I think actually we have an excellent 10-year mental health plan here in British Columbia. The challenge is that it's not, the investment has not been made to implement it. So that plan actually drew on the best practices in other jurisdictions internationally and nationally. So in some respects we have what we need. We just need to put the resources and the will to implement what we know is the right thing to do based on best practice evidence.
If you had a couple of priorities, what would they be?
Well, one thing is, I was reading that plan again prior to this meeting, and it's an excellent plan. It's got the best practice evidence from around the world in it. I think I would probably costed out. A lot of the money is already in budget. It's projected to be spent over the 10 years that are there. A lot of it is actually directed to developing new tools or applying them to get practice change happening on the front lines. I think one of the areas that we need to deal with is, one, supporting the primary care piece. So that was stronger in terms of its capacity to manage people earlier on. And two, I'd increase the supportive housing stock for people who are vulnerable. And so those would be the two areas that I think I'd look at investing in.
We will be back to those and other topics on this. Stay with us on Voice of BC.
It's one of the public policy mysteries that mental health doesn't have more political clout. This is a condition that will seriously affect, 1 out of 7 or 1 out of 5 British Columbians at some time in their lifetime. And yet, over the years, governments of all stripes have given it low priority. It just doesn't seem to make the list of urgent health issues.
Your source for in-depth, local political coverage. This is Shaw TV, your local voice.
Crime happens, but where it happens and who becomes the victim can be influenced by you and your community. As the eyes and ears of their neighborhoods, Block Watch programs assist police by reporting suspicious activity.
I'm witnessing a theft from a vehicle.
To learn more about crime prevention in your neighborhood, contact your local police department or the Block Watch Society of BC.
If you would like to contact us at Voice of BC, write to us. Our mailing address is 111 1925 Blanchard Street, Victoria, BC, V8T 4J2, or send us an email to vobc@shaw.ca.
What's your thing?
Bugs. My thing's sound effects. Here's a T-Rex.
Nobody's good at everything, but everybody's good at something. What's your thing?
I think our society in general is perplexed by what they need to do in order to support people with mental health challenges, particularly young people and early onset with challenges such as schizophrenia or depression, etc. So I think it's to some degree there seems to be a, we don't know what to do, so maybe we won't do anything.
Welcome back to Voice of BC. What do we do on the show when we're away and you're watching those breaks? In this case, we had a discussion off air between Dr. Perry Kendall and Bob Plekas about whether or not a standalone ministry is the right way to deal with this. So rather than revisit that argument during the show, what I'm going to do is I'm going to call this next clip, which is the opposition critic Shane Simpson, talking about another possible way to get at least an office that deals with this issue comprehensively. Here's Shane.
We had a mental health advocate in 2001. We really need to look hard at whether that kind of responsibility has to be given to somebody again. You know, the children's representative obviously does a very effective job at making sure those issues that affect children and youth are put on the table. I think there's a legitimate question to say, do we need somebody who fulfills that kind of role around the issue of mental health and people who face those challenges in our province and is able to put those questions on the public agenda in the way that that Ms. Terpel-Lafond is able to do for children and youth.
So we have these independent standalone officers of the legislature. Would that maybe be different than having a ministry?
Yeah, I would have some concerns around trying to separate out a bureaucracy and a budget and a separate ministry. I think it's so interweaved and interwoven with the primary care, the community base, the hospital sector where you absolutely need it. But I think it's fairly self-evident that if you get the right personality with the right office and the right mandate, they can certainly bring a lot of attention and spotlight to issues and highlight them.
What do you think of the advocate idea?
I like the advocate idea. I like the special ministry idea because it provides transparency and you can get in and lobby for your own stuff. But the advocate, you got to be careful with the advocate. There's no doubt, because when I went back to do the children and families ministry, we had 3 kind of children's commissioners, and only one of the 3, Cindy Morton, was at all effective. This person has been very effective in raising the profile, and partly because she's an exceptional person herself.
You're referring to Mary Ellen Trefalt.
An exceptional person who's done an exceptional job. However, having said that, she hasn't been able to get the ministry budget increased, partly because of her combative style as well, because she angered the government and the Treasury Board about the things she was saying. So sometimes a person who can really raise the profile can put the burr too far under the saddle of the horse, and they won't haul them down to the stable to give them the kind of stuff they want. Another kind of personality may drive the budget, because the budget is how you count in government. And they could have done with an awful lot more money in children and families and less rhetoric, I think. But there's no doubt, if you want to raise the profile, and that's a key issue here, that kind of person is exceptional.
Question from Bill Thielman. We touched on this a little earlier, but this is a good way of putting it. Here's Bill.
Perry and Bob, we've seen a lot of problems with street homelessness year after year after year for decades now. It's been improving in some locations and not others, but fundamentally there's something wrong. I've increasingly felt, and not comfortably so, that we may have to look at actually taking some people off the streets for their own good and against their will, in order for them to get the sort of treatment and medication that they need to help them. What's your view?
Would that deal with some of this undiagnosed problem that you've talked about?
I think you'd have to be very careful. You'd have to be sure that you had a place where you could actually put people where they would get the treatment and the assistance that they needed. I mean, there are provisions under the Mental Health Act for involuntary commitment. Part of the issue is when you get involuntarily committed, can you get the access to what you really need? Part of the issue around the homelessness piece is you have multiple chronic offenders who may have both psychiatric and mental health issues, and there are provisions, I think, for sort of taking them out of circulation. I want to see that the system was there and responsive before I started talking about taking people off the streets involuntarily. If we can't build a system that can take people off the streets voluntarily, I have some doubts about our capacity or where we'd put them once we took them off involuntarily. A lot of those people are in jails currently.
Yeah, well, I mean, what do we have left in terms of what people would imagine? I assume he means that we would have a provincial mental hospital where these people would be detained, but they would be getting treatment. Do we have such a thing or anything close to it?
Well, we're closing down Riverview. We do have places for people who are really seriously, totally incapacitated and incompetent. But the idea in closing down Riverview 25 years ago, as you said, was we could create better services in the community. I don't think we managed to do that. So I think it would be stepping back to recreate Riverview for those people when we could probably manage a lot of that problem if we were able to build the places where people could go voluntarily with the supports that they need.
I said we weren't going to do a lot on extreme cases, but we are going to do this one. Here's David Schreck.
Guilty by reason of insanity. Can anything be done to depoliticize the populist reaction of wanting to punish those who commit crimes because they are mentally ill?
I found it incredible on the recent case that everybody knows about. This has actually been in our law for 200 years, that you cannot be locked up as a criminal if a court finds you incapable, mental incapacity. It's not some new crackpot idea that was dreamed up by a bunch of pointy-headed liberal intellectuals in the last 10 years. It's been around for 200 years.
Yeah. And the courts do a lot about that. But David's question about, can we do something to change the public's mind? No. I mean, it's over time, I guess, and if you're sitting in Treasury Board fighting for some resources, you say, oh, sure, Minister, you can do it if you just fund this program for the next 7 years. If we can't change the whole standard of people's looking and viewing mental illness and trying to encourage mental health, which is the other side we haven't talked much about, but is something that we should be doing,
we will get to
then we're never going to change the stigma.
Is the diagnosis now sufficiently scientific that you can be confident about it, or is there still so many unknowns that even doctors don't know?
Well, it comes down to a legal concept of a guilty mind, I think, and somebody's opinion is whether somebody was capable of making a distinction between right or wrong at the time. I think part of the stigma or part of the pressure is that maybe somebody gets away with it and they're getting a free walk. They're not actually. They're being committed to a forensic institution, basically at the pleasure of the medical care professional until they feel that they're appropriate or in their right minds enough to come out. Then when somebody does something like, you know, and slaughter a family, and then they find that they're getting guided day parole because now they're in their right mind. Some people have an intrinsic sense that there's something really wrong here.
Well, I mean, I understand it, but it isn't, as I said, it is something that the justice system has been wrestling with for, as they say, 200 years. Let's go to this one. Leader of the Green Party, Jane Sturck, question about caregivers. Here's Jane.
I have a friend who works for the Vancouver Island Health Authority in trying to arrange respite care for people who are looking after elderly people with dementia and Alzheimer's. And they are finding that these people are isolated and that there are absolutely no services for them. In one case, there was an elderly woman looking after a husband with Alzheimer's and a son with schizophrenia. Do you think that mental health problems like this can ever be solved within our current healthcare system?
So we're talking about this wave that's coming at us. And no relief from that. I mean, if you've got your partner of 50 years who's, you know, seriously incapacitated and you want to stay home with them, there's not much relief.
No relief. And I mean, the problem, no, that's not true. We are trying to change the way we provide relief. We are trying to do more of this. It comes down again to the issue of resources and the allocation of those resources within the system. And I think there are programs, and I think we might get to this with what GPs are doing, and we're trying to get it into the schools, and we're trying to work on the front end. But you're always going to have anecdotal evidence everywhere of a case like Jane raises. And you're always going to have that kind of issue trying to be dealt with by families. Years ago, families played much more active role in this. Some cultures play a much more active role than some other cultures. But it is a true story. You're going to find those cases, I think, forever, because they always people who slip through the cracks.
And as the population ages, we're going to see more people with dementia, and so that sandwich generation can be looking after sick kids, and they can be looking after sick or incapacitated or dementing parents as well. And so either we pump more money in, which I mean, I think there's clearly need for increased resources, or we reallocate from the existing priorities, which, as you've pointed out, are the ones that tend to get prioritized because there's more of a vocal cry for them.
You highlighted the issue of housing here with a question about it. Shane Simpson.
There is an issue here that relates to how you provide the operating services and the resources that go into housing. We know that in the government buying the SROs, building some of the other housing that have now been contracted to nonprofit organizations to manage on their behalf, there has always been tension that the government's not provided sufficient funds for operating to allow the kind of staffing levels that people who are very hard to house and have complex issues require in order to provide a safe and secure place for folks to live.
It strikes me that he referred to SROs, which are these hotels that the government's been buying and converting. It must still be less drain on public resources if you can have people staying in a more like an apartment complex or a hotel, or home care with somebody dropping in on them, than having to have them in either a jail or a hospital.
Yeah, absolutely. Simon Fraser University, the Centre for Applied Research in Mental Health and Addictions, did a very comprehensive study, compelling study, I think it was in about 2007, where they looked at the cost of people who were unhoused with mental health and addictions, the total social costs, including emergency room visits, trips to the courts, trips in jail, etc., and it was about $50,000 a year. Then they looked at what the best or the most intensive housing supports would be, including the housing plus the support teams. It was about $37,000. So if you can work the finances, there's clearly a cost benefit to society in actually doing the right thing that we know that works, as well as the benefit to the individual.
I always thought about Plekas that a good financial argument like that would sway Treasury Board.
It always does, because when I looked at that study, I think that they came up with like $200 million worth of savings that you could generate out of that. The trouble is you have to say to Treasury Board, we just need another $100 million for the next 3 years, and then we'll save you $200 million. And they go, yeah.
We've heard that before.
We've heard that.
Yeah.
We've heard that 1,000 times before.
Don McTavish, Victoria Kool-Aid, here we go.
No one model will fit all situations. People do need choice. We know that from housing studies. They have to have some ability to choose where they live, how they want to live, and it costs money to have some supports in place for them. So a variety of models, from rent-to-own to ongoing subsidies attached to the person, they just need to be tailored to the individual. I think a mix of market and purpose-built housing and a variety of the housing is good, so a number of models can be appropriate. I guess where we're limited is where do the funds come from to pay for what operational supports are necessary, and where are the actual locations where we'll find housing for people.
You said earlier that this is a sufficiently complex problem that you need a variety of models for dealing with it too.
Mm-hmm. Yeah, absolutely. A lot of the people who are currently on the streets or couch surfing would be quite happy with low, low rent or subsidized housing. Others need some kind of supports to keep them going. Others need very intensive supports, and still others need what you might call forensic, assertive community treatment teams. And all of those models have been tried in North America. I think New York City is pioneering some of them. San Francisco is in Europe. And we're starting to see that sort of build up here, but it's slow, and we have competing priorities. For infrastructure, for example, is it the Blue Bridge? Is it light rail transit? Is it a sewage treatment system? I don't think we can have everything, so it depends where we want to put our dollars.
But if one of the things in the system is we are going to provide treatment, presumably you want enough of a mix that you're not doing exceptionally expensive treatment and care for people who don't need it.
Yeah, absolutely. And I think and it's possible to judge and guess, and to make an allocation based on people's needs, what they do need and when they need it. And when I was working on the Mayor's Task Force on Homelessness in Victoria, we brought all the community agencies together that were serving people in downtown Victoria. And there were many of them, but many of them had never actually sat down and talked to each other or figured out how their work related to somebody else's work, or who or how many of those agencies were actually serving the same client. And one of the things that came out of that was a commitment to work together to sort of follow the client, as opposed to having the client bounce from one service to another.
It's the terrible part of programs. You get people who run programs, and you get clients who aren't programs. I mean, they're people. Yes. And so you've got to start that focus on the client rather than on the program we've got. And you hear the stories, people go in and say, well, I don't fit into that program. Well, it shouldn't matter. It's the client that matters, and it's no cookie cutter. What I liked about Don's ideas was there was a real plethora of ideas there, including giving somebody a voucher of some kind where they could buy service. We need to try that, and we need to try as many different models as we can to find out what works in different situations.
Mm-hmm. I think that's not a bad approach for a lot of government programs, that we, even in healthcare and that there's a variety of things you're going to try to deal with issues. We got Dr. Michael Prince at UVic to suggest a number of things, and he did a lot of things for us, and we can only use a few of them. But here is one of his observations. Michael Prince.
Numbers do talk in politics, and seniors compared to young British Columbians still vote in large numbers. I mean, our voting turnout rates might be dropping down to the 50% rate, but certainly within middle and older British Columbians, that rate is still in the 70 to 80% rate. So politicians are not lost on that trend. And certainly, as particularly baby boomers are dealing with aged parents now, and as we ourselves move into the years and experience more Alzheimer's or dementia amongst us, there's still a lot of fear and stigma around those conditions. So that might be the driver, quite frankly, that will make this more politically irresistible for politicians to have to address.
You mentioned some cultures deal with this differently. I'm not sure ours is going to go back to multi-generational households where the aged parents live in one part of the house and the middle generation lives in another, and the kids are playing in the yard.
No matter how many times I threaten my children, they say I'm not coming, so
To look after you,
not
yeah.
going to happen. But I think I talked to Michael about this, and I was laughing. I said, you know, the problem with this thesis that this tsunami of Alzheimer's and dementia is going to wash over us is that most people have just two parents. And I can tell you, after going through it with both my parents, my mother for about 14 months and my father for only a couple of months, that by the time they both passed, I wasn't about to go out and join a protest march. I had had it. The emotional strain of that was so great that when it was over, I felt relief. I mean, I was sad, but I felt relief. And I wasn't about to try and create a movement to get better funding or better programs for someone else. It was over, and it was over in my life, and I was, it's horrible to say, grateful that I had got through that passage. And I think that's the problem with thinking that all of a sudden, because there's more numbers, we may all of a sudden become more cognizant of the problem.
Yeah, I think that there will be an increasing awareness of it, obviously, and I think there will be increasing pressures. But I think we probably will see more multi-generational housing. Certainly in Oak Bay, though, that isn't something that's going to rush in. I can tell you, secondary suites has been debated for 20 years. It's probably going to be debated for another 20 years. There are community groups who are solidly against it. The other thing is that not all of us live in the same cities with our parents or our children anymore. We're quite a diverse and mobile society, so that's changed.
Yes.
We're not a river valley culture that hasn't budged in 3,000 years.
That, you make a good point, and I noticed the Atlantic provinces are seeking more federal transfer payments for health care because all their kids, I mean, this is a generalization, all their kids have left for jobs in Alberta and British Columbia, and the old folks are left back at home with no one to look after them. So on that observation, cheery as it is, we will take a brief break on Voice of BC. Stay with us.
This new premier has an opportunity in the next year or two. If she does represent change, this would be a very welcome one. It would be across party lines, it would across communities. This affects all sorts of people and communities and families in our province. I can't think of a better one, really, quite frankly, to launch a new initiative.
Producing over 9,000 hours of local programming every year. This is Shaw TV.
As I'm driving to work, I can feel the anxiety building. My stomach starts to get sick. I start to sweat.
It's a feeling of terror, like a life and death situation, basically.
I always feel like I'm, under a spotlight.
I would kill myself at a certain point if things didn't get better.
Anxiety and depressive disorders are the most common of all mental illnesses. For a free mental health screening, call our toll-free number or visit our website today.
Missed something on Voice of BC? Catch an encore presentation of this show on your local Shaw TV. If you live in the Lower Mainland, Voice of BC rebroadcasts Saturday morning at 10:30 and Sunday afternoon at 4. On Vancouver Island, watch Voice of BC Saturday at 10 a.m. or Sunday afternoon at 2. To find out when Voice of BC rebroadcasts in all other parts of the province, please contact your local Shaw TV or check the TV listings for your area.
Kidney disease affects an estimated 2 million Canadians. Many don't even know they have it. But thanks to the Kidney Foundation of Canada's innovative programs and vital research, countless people have been able to turn to us to help them manage, delay, and in some cases even prevent the disease. We're the Kidney Foundation of Canada. Please support us. We're behind you all the way.
Many people in our communities, in my community, who are struggling with mental illness, who are struggling with addiction issues, they need health services. They need the support in place so that they can have the opportunity to succeed.
Welcome back to Voice of BC. Special show on mental illness, mental health. Dr. Perry Kendall, Bob Plekas. I think we'll go straight to the Watchdogs question. Here she is, BC's Child and Youth Representative, Mary Ellen Turple-Lafond.
On adolescent mental health, there seems to be a lot of concerns in British Columbia, in my experience to date, with adolescents who are also using substances, sometimes to address their mental health issues, and sometimes they exacerbate their mental health issues. Are we doing enough about addictions and mental health, particularly for adolescents in BC?
How do you get at it if you say, well, obviously institutionalizing people isn't appropriate, especially if you don't have a place to put them. But how do you get to problems she's identified, such as young people?
Again, it's not, there's not a simple answer. If there was a simple answer, we would have found it years ago. So I think you need to look at the pathways to vulnerability, and some of them starts with baby rats. Baby rats who are licked by their mothers are much more resistant to stress. Their genetics develop in a different way, and I think the same can be applied to human babies as well. So if we can give all babies or more babies a really, secure upbringing, which involves supporting mothers, supporting fathers, supporting housing, and then trace them through the educational system. And if you look at the work of Clyde Hertzman, there's clearly, large amounts of deficits in kids getting to kindergarten, being not even ready for school yet. So I think we need to start way back there. And there are some initiatives in the mental health plan which talk about an enhanced nurse family visiting program for focusing on the most vulnerable. That'll make differences. Those differences will show up in school readiness, in attachment. There are programs that you can identify kids who are not going to be attached in school, and there are ways you can give them the skills they need and the supports they need to be attached in school. That really reduces the vulnerability, so you'll see fewer kids experimenting or making stupid choices. And if they do, they'll be a lot less vulnerable to actually falling into a spiral where they become disconnected, they fall out of school, they end up on the streets, and they get into trouble. I think we can also address the way we actually educate kids and give them skills. Part of our problem is it's a bit like early sex education. If you tell them how to do it or how not to get into trouble, then we're encouraging them to do it. We're sending the wrong message. So what we do know is that a just say no message doesn't work for kids, and it certainly doesn't work for vulnerable kids. But it's quite a contentious area as to what you actually tell kids about drugs and how to use them. If you're going to use them, how to use them safely so that you don't end up in trouble or with problems. Some of the worst things we could do, and another Plecas, Darryl Plecas, who's an RCMP researcher in the Fraser Valley, said one of the worst things you can do is the absolutely no tolerance, where you find a kid who's smoking drugs or drinking alcohol and you kick them out. Then you completely divorce them from any of the support systems that could work with them and maybe help to bring them back. It's not simple. I don't say it'll work for 100% of the kids, but you could certainly diminish the harms and the number of kids who are starting early. You could postpone that. Even a year makes a huge difference. If you postpone alcohol or tobacco or other drugs for a year or two, it makes a huge difference to the long-term outcomes.
What you're saying, I'm glad we've gotten to this point, because we've talked about illness, and maybe we started at illness and we're working our way back to health, but it is possible to promote mental health.
It is possible to promote mental health, and I think that one of the issues we've got to deal with and is you need to sort of try a triangle. Just take a triangle like this, and at the top is mental health, and then as you go down you get people who need some help, and then as you go down and as you get right to the bottom part, you've got the 130,000 British Columbians who are affected and seriously affected, and right at the point are the homeless on the street with addictions and mental health issues. Then take another triangle, only turn it the other way, and it goes along the bottom at the top. That's the money we spend. So we spend the money on this front end, and we spend very little on the mental health part at the top. And somehow we've got to change that second triangle. We've got to broaden the base so that there's more resources for housing and treatment at that end, but we've got to change the shape a little bit so that we're actually putting funds into mental health, because that's the way to secure the future with young people and with the general population.
Bob, the triangle Bob's discussed, and I heard you refer to Hertzman at UBC. I attended a conference a while ago on early childhood learning, and very much the message of that is that money spent at heading off problems between birth and the time children go into the first institution we provide in society, school, in grade 5, when they're 5, that we need to think about a social institution between birth and age 5 that addresses these broad issues, and we'll have an awful lot less problems at the end of the pyramid that Bob was talking about.
Yeah, absolutely.
And that's maybe a topic for another show. I wanted to get to the primary care general practitioner issue and getting us there, at least getting us started on it. It's David Schreck. Here's David.
There's a problem with general practitioners prescribing medications for various forms of mental illness. What's being done to better equip general practitioners to either make a referral or develop the skills they need themselves?
So we hear a lot of grumbling about people being medicated.
Yes. And I think there's issues with over-medication and appropriate medication, and there's clearly issues at the other end of the system with under-medication. People who ought to be on meds just aren't. I think that the government, over the times I've been in BC, have actually developed a much better rapprochement with the BC Medical Association in terms of the general practice groups, and looking at trying to change general practice so that it actually has the supports that it needs. I mean, a general practitioner's, the primary care system was essentially set up to deal with short-term encounters with young, relatively healthy people who had brief illnesses from which they recovered. And what we're talking about here is a system that is dealing with a chronic or relapsing conditions. And general practitioners don't necessarily have the supports in terms of psychiatric social workers or psychiatric nurses or psychologists. They don't necessarily work in groups that can support each other, and they don't necessarily have the tools to recognize and deal with the conditions, anxiety, depression, postpartum depression. But there is work going on that's quite encouraging to me between the BCMA and the Ministry of Health to develop those tools, to look at ways of rewarding longer encounters, to develop mental health plans. But it takes a long time to change medical practice, unfortunately. It takes longer than you might think it is. It isn't just, oh, here's a great idea, this will work. Fine, we'll all adopt it. You need practice leaders, you need to change the nature of the support systems and even the health records so as you can trace people through. I think work is being done on that. It would be nice if it could be done faster and more comprehensively, but I think it is underway. I think there is an understanding in the profession that this needs to happen.
We had health ministers on the show talk about that, but essentially, if we can just go into it in a little bit more detail, is it the idea that the general practitioner would have like a community clinic they would work through, or a group of specialists to deal with these chronic conditions? Because I've heard it referred to in relation to chronic illness as well. Diabetes is something that needs a lot of management.
Yeah. Well, I think if you can have a number of physicians working together, you're obviously in a better position to spell each other off, to offer 24-hour care. If you can add to those groups more generic supports like nurse educators, or if it's a psychiatric practice, a couple of psychiatric nurses, if you could then link that back to a hospital where you had a psychiatrist who could give you advice, you could pick up the phone and talk about an issue with a medication, is it right or not? If that patient then, if you knew that if you couldn't cope with that patient, you had somewhere where that person could go. These are sort of best practice models that exist in Toronto. Edmonton has got a very similar program for the very frail senior, particularly those who are starting to dement. They work really well. They keep these people out of hospital, functioning independently, and basically healthier. And in some cases, you might want to add a legal advocate. An awful lot of depression and anxiety, I think, comes from people who are just not aware of what their legal rights are. I remember trying to treat somebody in Ontario, a woman, for depression, and eventually I sent her to a psychiatrist who referred her to a lawyer. He got her free legal advice, and she started getting some of the benefits she was due to from her husband, and felt a lot better about herself. And so I thought I learned something from that.
It's maybe the first time in history that anybody has ever got rid of depression by going to see a lawyer. Yes. About that. You've done an awful lot of negotiations in the public sector in your many years there. Have you ever had to negotiate with the doctors?
I never have. I never have negotiated with the doctors. It's one of the great stories of my life, along with I never went to the health ministry as deputy minister.
Okay, well, we'll leave that one alone. Then we've got a couple more things we want to get to before the show is over. Back to Michael Prince, mental health in prisons. Here's Michael.
We've heard a lot at the national level about that in federal penitentiaries and prisons that upwards of 30% of inmates have mental health issues. Either that's what led them into the prison, or it's been one of the contributing factors. We often forget that there's also a provincial prison population in our correctional facilities. And so what does Christy Clark need to do in tackling that sort of forgotten, unknown issue of mental health?
Is that beyond the reach of the medical health officers and so forth if once they're in prison?
Well, we do. I mean, the government does contract for health services for prisoners, and that contract can include certainly action around alcoholism and addictions, and there are now methadone maintenance programs in prisons, which is certainly a leap over where they were 10 years ago. I think if a lot of what we were talking about in primary care and moving upstream and managing conditions could be done better, we might be reducing the prison population. I think there are also policies around who you prosecute and what you do with them that can increase the prison population. And a lot of my colleagues and I have serious concerns about some of the impacts of the Tough on Crime federal agenda and what that's going to roll out to in terms of the prison population, who's going to end up there.
But you do end up with this. We say we don't have institutions anymore,
Yeah.
but about 50% of the prison population have mental health issues or addiction issues. And on the women's side, maybe as high as 70%. I mean, it is shocking, and they're institutionalized in a place where they don't get very good service because they're in a penitentiary or in a correctional facility, and they come out, and we expect them to come out and join society. They go in with problems, they get worse in the institution, and they come out perhaps worse than when they went in. We shouldn't be surprised.
Related question, Bob Simpson, about the police. Here's Bob.
Increasingly, the RCMP and police are being asked to deal with individuals who have mental health problems. The RCMP and the police have indicated publicly they are not equipped to deal with those individuals. Is that an issue of lack of funding for mental health and addiction services? And how do we address mental health issues outside of turning them into police issues?
Who do they call?
Well, in the best models, you've established a linkage between the local police force and the mental health team. And so you have specially trained mental health social workers who are on call and who can go out to these calls, and then you train the police on how to de-escalate rather than escalate, how to recognize a condition, how to de-escalate it, when to take a mental health worker along, and how to do the approaches. Those are the best models. I think they can be done without additional funding by reallocating the resources that we have. The mental health workers are there, the police are there. It's just a question of putting them together and putting the appropriate training in place.
We got a little bit of time left. Let's maybe just talk in general again, just from what we've talked about on the show. Go back a little bit over the idea of what should be our priorities. If you're going to try to make progress on this issue, would you start at the front end with more early childhood things and more preventive and more mental health, or would you be working at the illness end?
I would work at both ends of that spectrum, actually. I would work at the upfront end, but that's by its very nature, if you're investing in the health of children, going to take years before you see the results, at least 5 or 6 or 7 years anyway for the kindergarten. I would also, in that time, work on the primary care sector, trying to build and strengthen that sector, including community supports, practice support tools, etc. And I think working on pulling the addictions and the mental health piece together. And one of the reviews that we did in Victoria, looking at how the system worked, you're expected to graduate from one place to another and meet the criteria of the programs, as you said. And so if you fail at any point, you're back to the beginning. You're back on the street, or you're out of the system. And you can bounce around between the systems forever and never get to an end point. So reforming what's already in that system to make it more welcoming, so that any door is the right door and you can get a range of services appropriate to your needs, that could be done without much in the way of additional resourcing, just in restructuring how it works, I think.
Yeah. Thank you very much, Dr. Kendall. That was a good summary, and I appreciate it at the end. And Mr. Plekas, your insights on this show are always appreciated. I like the insults, too. Maybe we'll get to those one of these days. Thanks to Bob Plekas for being on the show. Thanks to Dr. Perry Kendall.
Thank you.
Thank you for watching Voice of BC, bringing the legislature, BC politics, and public policy issues into your living room. Good night.